This is the Working with Warriors podcast by the team at the Regional Men's Health Initiative.
Hello and welcome. My name's Owen Caddo and I'm joined today by fellow team members Terry and Glenn. How you going?
Very good, thanks, Owen.
G'day, Owen. Good to be here, mate.
Yeah, good guys. In the first podcast back, we talked about men's sexual being and what is it, and we talked about it not just being sexually active, but all the bits that make us a man. And this episode, we're just going to talk about the physical aspects from the prostate point of view and erectile dysfunction. I guess the reason half those issues are a problem is because we don't talk about it. And as blokes, as we've already discussed, and it's a hard conversation to have, not only with our partners, but especially if we take ourselves off to a GP, because it's one of those subjects that we don't talk about. But there's some research too about the ageing and identity, which is just really important, because in that last podcast we talked about in our 50s and our 60s and our 70s and 80s, we're all 50, 60, 70, 80% dysfunctional from a sexual well-being point of view, but this article kind of backs it up a little bit. Terry?
Yeah, look, an article out by Email, one of our leading men's health organisations, and they just highlight the fact that changes in sexual function and libido are a natural part of ageing, but can be difficult to accept, and that's directly linked because sexuality is often tied to us blokes, our vitality and our identity. So who we are, our passions, interests, what makes us tick. So changes in this area can affect intimate relationships, and that leads to issues with self-esteem and connection with a partner, which we discussed in the previous podcast. But also the society stigma around ageing and sexuality can make it even more challenging to discuss and address these changes, leaving men to struggle in silence. And we talk about that warrior attitude of blokes, talking less and going into their cave. And just a bit of personal antidote on some of those social cultural factors around issues below the belt. My young fella who's in year 10 now, but I'm sure it was last year, they brought home the sexual reproductive charts for science and had to name all the bits, all the women's bits and all the men's bits. And on that chart, the prostate gland wasn't labelled. And I just found that amazing in today's age, that boys still aren't educated, because it's a vital part of our reproductive system.
Absolutely, Terry, and that answers a fair few questions early on around education, and we're not experts by any way on our prostate and its functions, but we have a discussion around it in the language that people want to talk to us about and we talk to them about, and that if that facilitates one person to approach it with his GP or his partner, well, we're in front. But we've got a long way to go.
Yeah, definitely.
So I guess just starting with the prostate, because there's a lot of confusion, and the first bit of confusion, and I've got to say, because I'm at a men's shed or I'm talking to a bunch of blokes, and the old bloke says, about my prostate. And I have to say, mate, if you've got a prostate, you're lying on your back and you're stuffed. It's the prostate. So we just get that said to us all the time, which is quite funny in itself. But so it is the prostate, but it's an important part of the male reproductive system. It's pretty important when we're trying to have kids, because its role is to provide the fluid, the sticky stuff. 70% of the fluid that comes out is part of that fluid.
That fluid that helps protect and transfer the sperm. Yep.
And, originally the prostate is the size of a walnut, but, it doubles in size from that 20 to 50 and then doubles in size again by the age 80. So the reason of saying that is because it surrounds the top part of our urethra, and our urethra goes through it. One of the biggest issues is peeing problems and incontinence and infections, which we'll talk a bit more about in a minute. But it causes us a lot of grief, and it's a shit of a design, for want of a better word, in our body, because it's hard to operate on and hard to get working when it's not.
Yeah, look, and we will highlight that sometimes a few of those signs and symptoms there, around poor stream, getting up 3 to 5 times a night. So that restriction of that urethra, can cause difficulty to fully evacuate the bladder, so that retention of unit, so regular urinary tract infections. So, it can be painful, embarrassing for guys, that leaking or that dribbling. We joke about, as a young fella, we're in the urinal being able to pee over the edge of the urinal, but as we get a bit older, you got to watch out that you don't dribble on your slippers.
Yeah.
So really common side effects or symptoms, associated with prostate enlargement, but sometimes they just get labelled as only associated with prostate cancer. So I think we need to say that up front, that, just up front, that while prostate cancer does kill about 3,000 Australians a year, in Australia they reckon there's approximately 2.4 million blokes living with a prostate problem, and most predominantly that is that prostate enlargement, so referred to as BPH or benign prostatic hyperplasia.
Yep. Look, we're going to talk about that, Terry, and we have to, because as recently the other night on the news we heard a reporter refer to the symptoms of prostate cancer, and when we talk about that in a minute, there is still mass confusion, and as we explain what we're going to explain, I hope things become a bit clearer. But the three things we want to talk about, I guess, are prostate enlargement, prostatitis, and then prostate cancer. So firstly, the things about prostate enlargement, Terry, which you've alluded to, but we need to repeat, is it's the most common disease, prostate disease in men is enlargement, and it's the symptoms usually are around urination problems.
Yes.
And we need to talk about that in its context, because it affects a lot of us as blokes.
Those symptoms are most likely to be urination problems in terms of poor stream, getting up 3 to 5 times a night, incontinence, retention of urine, regular urinary tract infections, and it can be painful and lead to prostatitis and majorly affect your life. And it's obviously, we've all had the night where we've had 1 or 2 pints or 3, and then that's resulted in us constantly needing to get up and go to the toilet. This is more than that. This is sort of that happening through not an unexplained cause, but just through the need to go.
And we have had in the past at our pit stop program, and I use this guy's story all the time with permission, but he was at the pit stop and he put a ring around the 10 sheets on our shock absorbers and said, "I've got prostate cancer." And I said, "Oh, geez, that's no good. When were you diagnosed?" And he said, "Oh, I haven't been, but I've been in a nappy for 3 months, because that's what I've got." And he said, "Well, more than likely you haven't. You've got an enlarged prostate and you need to have a talk about it." And he said, "That's what my wife's been telling me." So the upshot of that story is he got himself to a referral via a pathway that we'd suggested, and he had a large prostate, had appropriate treatment, and he's fine, 100% fine. So we just put ourselves under pressure, and we just need to harbour that prostate enlargement is the biggest physical issue that we have with prostate issues, even though prostate cancer does kill people.
Yeah, look, and I think we're bringing it down just to a wellbeing level. We've done a lot of work at pit stops over the years with Continence Foundation Australia, and the continence nurses have come out and done pelvic floor exercises with blokes, and it is about us guys just being a bit more in tune with our body. So being aware, when we talk about changes in your urination, or if we're talking about bowel cancer, being aware of your bowel movements. So we do form habits with our bladder and bowel movements. So it is, what's your normal, with obviously bowel movements. Some blokes, it's first thing in the morning, you do your best job, but for other people it can be, not as regular. But and I had the continence nurse explain that some guys never actually fully train their bladder to actually fill. So, the old fellas who are a bit cautious, before I go out, I better go to the toilet. But it is good in those, early years to train our bladder to fully fill up and get that proper bladder health happening, and then being aware of any changes to our normal.
Look, so I guess that's prostate enlargement, guys, and there's a whole lot more to it. We're just giving you a snippet so we've got an understanding, hopefully. And so I guess prostate enlargement is exactly how you've explained it, Glenn, and is enlargement. The second issue that we do have is prostatitis, and that is an inflammation of the prostate, and that causes pain and in around the gland. So once again, it causes us usually an infection and issues around making our system work. So we won't go into that in a big way, but that is another issue that needs definition from prostate enlargement. So it's inflammation is the second one. Then I guess the third one and the big one which we talk about is prostate cancer, and the fact that it kills a fair few Australians every year, and the diagnosis is on the up. And that's a good thing, because there's a lot of the technology, and I'll say it more than once today, the technology and innovation in treatment of prostate cancer is incredible. It has changed so much in the last 15 years, and particularly again in the last 5 years. And when you read the latest research going on, it is significantly going to change again in the next 5 years. So we won't go into those treatments today, but we will go into what prostate cancer is, I guess, and the definition of it. And put simply, it's the growth of abnormal prostate cells in our prostate from enlargement and prostatitis. So it's different from those two. It's this abnormal growth of cells. So about 2/3 of those cases, diagnosed cases are in Australia, men over 65 years of age, but the other third is obviously comes from younger men. So we just got to get away from thinking that it's an older man's disease, even though it predominantly happens in older men. The biggest problem with prostate cancer is there's no symptoms until well advanced. And this lies a few things that have changed in PSA testing, which we'll get onto in a minute, but the 4 risk factors are really important. And the risk factors are what a doctor or GP will have a discussion with you about, because that's what the research and treatment and diagnosis is quite often based on, and on the premise that there quite often is no symptoms. I'm going to probably say that 10 times, but we just have to keep reinforcing that. So the risk factors, Glenn.
So the risk factors are, if you've got a family history, that obviously predisposes you to be more likely. There's age, men over the age of 50. Diet, so a diet that's high in animal fat and proteins makes you more susceptible as well. And race can do it as well. So some of the darker skinned nations are more susceptible than Caucasians, but then that doesn't necessarily rule anyone out either, but it just means they're more susceptible.
And the important thing about those risk factors is that's what they are, but that predominates how a GP may discuss it with you. But if you're having any of those other symptoms that might be around enlarged prostate, we encourage guys, as we said before, to have a conversation with your GP and push it, because you are the best person to know your body physiology. And, from the latest research, I just want to read this paragraph out, short paragraph, and it summarises issues about prostate cancer. Localised prostate cancer can have no symptoms in some men. Others may have urinary problems, like men with BPH, enlarged prostate. But men with advanced prostate cancer may have blood in the urine and can have pain in their lower back, pelvis and thighs. So it's just really important to get that definition. Some of those BPH symptoms might exist, but predominantly there are no symptoms that can be attached to prostate cancer other than those risk factors.
That's why it's so important for us to be engaged with our GP, because if we're relying on going, I'll wait until I can see some risk factors before I look at anything, then finding out that that's only late stage that we get some of those symptoms, that makes it even more important that we're engaging with our GP throughout our lives.
Yep. So the common protocols for prostate cancer diagnosis as of the time of going to air, and that's the very important disclaimer, because this process has changed, but this is the most recent, and it does vary from individual to individual. But the common protocol for prostate cancer diagnosis currently is...
Yeah, look, we've said it 100 times, but it's having that initial discussion with your GP on those risk factors. And obviously from there, the first probably test that they will do is the PSA, which tests a protein in the blood, a prostate-specific antigen. So that's a benchmarking tool, and that's obviously ongoing. So if there's indication that there's been a sudden change or a spike or a really elevated level, that's when the GP will look at that option of whether they go for an ultrasound, MRI or the DRE, which is usually the thing that puts a number of guys off, that initial digital examination, but quite often that's done later on down the track. And then the only real way to know whether there's cancerous cells in there is through the biopsy, which will be referred off to, obviously now under guided ultrasound, as Owen said, the technology improvements, they can be a bit more targeted with the biopsies. And then through that ongoing process and discussions with your doctor, and obviously being referred to a urologist, the option of what the treatments are. And there's a whole range of them, Owen, and also the option of active surveillance.
Look, and we don't go into those when we're chatting with blokes, because there's plenty of experts with those options and they're changing, and that research is really powerful, and I'll refer to a bit in a minute. But just going back to that common protocol, that process that you recommended or read out there, Terry, and that we discuss in all our talks, it's really important because it's risk factors. Then the PSA benchmarking cops a fair bit of flack, but it's still saving lots of people's lives, and it's a legitimate test. It's not a direct indicator of us having prostate cancer, but it's a direct indicator of something AWOL in our system.
Can I give you just a little personal story on that?
Not too personal.
No, it's not too personal, but I was on a watch because my PSA bumped up slightly, and this is why it's so important that you have this relationship with your GP. And she said, listen, it's up a little bit. It's not into there's no alarm bells ringing, but rather than a 12 months, we're going to check you in 6 months. And the discussion was around the fact that she didn't think there was much to worry about. And I said it might be because I rode my bike from Bustleton to Yallingup and that might have aggravated things down there. But then after the 6 month check, it had returned. So that engagement with your GP is such an important thing.
The narrative behind it, you just nailed it, Glenn, because I was going to mention the two obvious things that affect our PSA is if you've been on a bike ride, and depending what antibiotics, drugs you might be on, and your doctor can only know that by having that discussion with you. And so much so that the research, those protocols will change, because there's just some current research right at the minute being tested about a saliva test. And that's right at the pointy end of this research. So the holy grail of testing might be there soon. But it's probably just appropriate to talk right at the minute about the changes for bloods, because there's a fair bit of conversation going around like they're charging me for it and they're not. As of 1st of November 2023, they introduced some new rules, and it was if you've got a significant family history of prostate cancer, you are eligible for one PSA test every year. That's why that family history is important, and that's what they base the research on, and that's what they're basing this decision on. If you haven't got a significant family history, the free PSA test is every 2 years. And I'll say that really pointedly, the free PSA test. These guidelines are being reviewed as we speak, even though they're only introduced in 2023. They're being reviewed right now. For the cost of a $30 or $60 blood test annually, I reckon when you're above 50 years of age is pretty cheap insurance and a good thing to have. So have that conversation with your doctor, because it's pretty important, and it might just it might be able to pick up some of the abnormalities, which gets us away from riding a bike and having drugs. Or the effect of drugs. I guess the other thing is just when we talk about our prostate and its position and its how it's physiologically in our body, we don't talk about, as blokes, we've never talked about pelvic floors enough, and we just think women have a pelvic floor, but we've all got pelvic floors, and we need to do some exercises whether we've got prostate cancer or we haven't, and with an enlarged prostate. And I reckon the best way I describe it to people to work out if they want to know what their pelvic floor is put a coffee cup in the freezer with nothing in it and freeze it, then drop your duds, do it in front of your wife so she know, or your partner so she know they know what you're doing, and slowly lift that frozen coffee mug to your nuts. And when you touch your nuts with that coffee cup, the reflex that you have in the muscles down there is your pelvic floor, boys. So it doesn't matter how old we are, you do that, and then that'll twig the brain as to, I've got a pelvic floor and let's do some exercise. And there's so much literature, and we will refer to Dr. Jo Milios a bit later in terms of giving out her details. But it's really important that we practice pelvic floor.
No, that's right, Owen, and you've just explained the layman's terms of the old nuts to guts exercise. I think Dr. Joe would probably refer it as the pelvic lift. The pelvic lift, I think I've heard it described as, pretending you're sitting on a big Harley and lifting your nuts to your guts is the way she explains it as well. So doing that's really important. Look, things like Pilates and yoga are also good things to strengthen that core, and it's just something sometimes as simple as just drawing that navel in towards your spine. They talk about as turning your core on, so it's not trying to tense up your hidden abs in there somewhere, but it's just sucking that belly button slightly in. Or even just that 30, we talk about finding that 30 minutes for a bit of exercise, and it needs to be quite brisk, get the heart going, get us moving. And then so often when blokes hit the wall, we talk, one of the big factors for blokes is that lack of sleep. So, the importance of getting a good night's rest. And I've said before, my little mantra, diet, exercise and sleep. If I can manage those three things, my well-being improves dramatically. And don't forget that importance of exercise, and sometimes they talk about eating 150 grams of nuts a week, almonds, are good ones, as well as sometimes those naturally red foods like beetroots, tomatoes and watermelon can also have a positive benefit towards our prostate due to some of those nutritional values and factors in that food. But also a lot of those foods are known to help reduce the risk of toxins and cancer in our body.
I think it's those red nuts are really important, and the almonds and those red foods like beetroot and tomatoes and all those things are really important. Diet's critically important. So I guess really at the end of this, the prostate cancer diagnosis, and we want three things, Glenn, and that trifecta of outcomes is important to keep us healthy and happy.
Yeah, and that trifecta of outcomes includes the cure. There's urinary incontinence in approximately 5% is permanent or ongoing, and erectile dysfunction approximately 75 to 85% permanent. But that also is why, and we do harp on it, about engaging with your GP and really discussing it, because there's some very different approaches from people, especially people who are diagnosed with it, and some immediately I want this out of me, and that needs to be a discussion, particularly around the point that sometimes prostate cancer can be very slow moving, and in discussion with your doctor, the doctor might actually say, listen, you're pretty advanced in, I know this conversation's happening with my dad at the moment, so pretty advanced in age, you might be going to die with it, you're not going to die of it. So that's why it's an important subject to really be talking to your GP about.
Look, it is, Glenn, and those things, the urinary continence and that erectile dysfunction, which we'll talk about in a minute, are really important to a lot of blokes, but it comes back to a bit of age and stage. And there is a fantastic new tool out by Prostate Cancer Foundation, Glenn, that I just can't repeat enough, that the information explosion, and we've got to get it out to more punters, but the amount of information and new products, both about that information, toolkits and research, is just profound. It's incredible.
Yeah, and so Prostate Cancer Foundation of Australia, who do some great work on their website, which is www.prostate.org.au, they've got their new prostate cancer survivorship toolkit, which is a mouthful. But previously, blokes have struggled to glean info from lots of different sources about their cancer journey. But this is now like a one-stop shop that covers things like risks and symptoms, testing and diagnosis, treatment and side effects, and advanced prostate cancer. So it can also link you to talk with a PCFA nurse and link you with support groups around Australia. So it's a fantastic resource that's available to everyone.
And I guess on the back of that, the idea of that toolkit and that amount of information is because you're not alone. There is contact points everywhere, there's pathways everywhere, but for us as blokes, sometimes they're pretty hard to connect with and sometimes deal with information overload, but it's a good primary source. Okay, I think we need to briefly talk about erectile dysfunction because it's can be part of that, an upshot of prostate cancer and even prostate issues. But I guess it's how it's described is when we can't get or keep an erection to allow sexual activity with penetration, and the symptoms are both physical and or psychological, and the research is pretty straight on it that 1 in 5 men will experience erectile dysfunction, and if you link some other disease to it, which we've already talked about, but many men with diabetes have problems getting an erection, and it's very common in men over 50 due to lack of sleep. And as we've already talked about, the 50s, 60s, 70s and 80s and 80% in those ages, a lot of it's to do with that psychosocial issues around our physical bits, and part of that's talking with our partners, and taking the issue to your GP. So there is a fair bit of help to around erectile dysfunction, Terry.
Yeah, look, many treatments. I mean, really important to rule out any of those physiological factors that might be going on. Flowing on from that, GPs can refer you to specialists in that area or sexologists, and some of those treatments can be around. Drugs, everyone has probably heard of the little blue pill, Viagra. Don't choke on it or you'll wake up with a stiff neck. As one of the first things they often go to, but, penis pumps, vacuums, and, we'll be chatting to Ditchy in our next podcast, who actually through his prostate cancer and loss of function actually ended up with a little pump.
Well, not a little pump, a big pump.
Big pump, yeah, no, it wasn't. He didn't mention that it was they had to order in an oversized one. And then things like penis rehabilitation, and blokes will often joke and scoff at this, but the project our Joe Milios is involved in, the penile project, is it, Owen? And they talk about doing penile warm-ups. Maybe not do it at work at the pre-start, but and it's even penile stretching arm. You've got some experience with it.
Yeah.
No, it's good to have a laugh, but I think on a serious note, we do really need to mention Dr. Joe Milios at Men's Health Complete Physiotherapy. And look, she does specialise in men's health, from blokes recovering from prostate cancer or suffering other men's health-related problems around bladder, bowel, pelvis, all that sexual function. She does collaborate with another lady, so Melissa Hadley Barrett. She runs Restorative Sexual Health Clinic, and these two ladies actually have collaborated on the Penis Project. So make sure you check out that as well for a bit more specialist clinical subject matter around this topic.
You mentioned there, Terry, that we are going to have our special guest, who is our current chairman as well, Ross Ditchburn, talk about his prostate cancer journey, and he mentioned about the big pump. It wasn't a little pump, so a big pump, and so we'll chat to him in our next podcast. But I guess we've got to reiterate a bit of stuff about the psychosocial and around how we operate as blokes, and some of the misinformation. There's a lot of information out there, but blokes will talk to each other. And we've just got to reiterate that every prostate cancer journey is an individual journey. There wouldn't be two cases the same. So how our body physiology reacts, how our treatment pathway occurs, and then how our post-treatment incontinence and erectile pathways, traject out. We just need to bear in mind that we do joke about it a lot, and we have to, but there's a simple urine test as well, isn't there, Glenn, that we talk about?
Yeah, and it might be relevant for at least some of us men. So the trick is to go outside and pee in the garden, and if the ants gather, then it's diabetes, and if you pee on your feet, it's prostate. If it smells like a barbecue, then it's possibly cholesterol. When you shake it, if your wrist hurts, it's possibly osteoarthritis. And if you return to the house with your penis still outside your pants, it's Alzheimer's.
Yes. Look, we do have to laugh about it because we've got to maintain our sense of humour when when we're getting poked and prodded and
Well, and it's just normalising a bit, isn't it, Owen, and making guys feel at ease to talk about it. And we joke about young fellas have always got their hand on it, but as we go through life, it can become a taboo and embarrassing subject for a lot of blokes.
Oh, it is for a lot of blokes, and it doesn't matter whether I'm a 20-year-old or 30-year-old or 70-year-old bloke. It's so having that connection with a partner, if you've got one, having that conversation with a GP and arming yourself with some important information because it's your health, and I just repeat, you know the physiological change in your body better than anyone else, and we've got to observe those, especially when it's around our man bits.
Exactly right, Owen. So just being a bit more in tune with your body and being aware of what's going on. And like we always talk about, acknowledging our relationships at the different stages it's at, we still got to maintain that connection and intimacy with our partner. And that starts with talking about where we're at physically and emotionally and mentally. Get to the GP straight away if we notice any changes or if we've got any concerns, have that conversation. Just being aware that as we get older, that sexual dysfunction does increase. There's in men over our 50s, and like we said, that increased risk for prostate cancer. And once again, any form of sexual dysfunction can be that sign there might be some other issues going on. So ruling out things like heart disease, might be getting some medications refined or revisited, and getting the physical health and mental health and sleep in check. And we've got to be in control. No one's going to come and do that stuff for us. We've got to work at having time for ourselves to relax, get a good night's rest, do some exercise, get involved it always helps to get back involved in your passions and interests with a group or a club, and that input versus output. Look, fueling our bodies with good healthy food and avoiding some of those trap foods. I think we've got to be careful of.
And we do have, we do have to have that conversation with the people around us, and there's so much information that we do have to become informed. And just to suggest to our listeners as well that in WA we are so privileged and honoured to have so many experts in terms of surgeons and oncologists and treatment pathways for prostate cancer, that we are world leaders, and we pick it up early, or pick up on any benign prostate issue, we can get it resolved. So, all right, thanks guys. We'll look forward to talking next time and talking with our special guest going forward. So thanks.
Thanks, Owen.
Good on you, Owen. Cheers, mate.
Thank you for listening to our Working with Warriors podcast series.
Talk to a mate, just let him